I'm sitting with Dr. David Kaufman, a professor and chairperson in Michigan State University's Department of Neurology and Ophthalmology, and also the Spartan football team neurologist. Thank you so much for being here.
Delighted.
So starting from being at one football game in 2012, to every home game in 2011, and then to every single game since 2012, how was the transition in your involvement with the team? Can you talk a little bit about that?
About 7 years ago, the athletic trainers rang me up on the phone and asked me what I do on Saturdays. And by then, the athletic trainers understood that mild traumatic brain injury, concussion, was going to become more and more of an issue. And at that time, they asked whether or not I could participate with the football team a little bit more closely. And in response to that, I began to, at their request, go to practices and then to the sidelines, and then following that, travel with the team. And so it was a very natural integration over the years. And then as concussion has emerged more and more prominently, it just seemed very natural that I would continue on in that capacity.
Okay, absolutely. And then we'll talk a little bit about your study with the football team later on. But first, it relates to something you said in your presentation with the MSU Neurosciences Club. You cannot diagnose a concussion by simply watching a play on television. So can you expand a little bit on that?
Well, most of us understand football from the stands or from watching on television, and one of the first things I learned being on the sidelines during football games is that it's far more complicated, far more intense than you would think on television. But with concussion, you have to, like any patient, you have to examine the patient to know what's wrong with them.
Absolutely.
And you can receive a blow on the football field, TV can cover it, and the athlete can be surprisingly fine following such a blow. Well, on the other hand, you can have what appears to be a very minor collision, and the player may have, the student athlete may at that time have a mild traumatic brain injury. What you have to do is go through the examination and determine whether or not there's been any involvement of the central nervous system.
Okay, absolutely. So what is that process of diagnosing a patient or a player? Can you describe then, you said the SCAT-3 in your presentation is a very popular way of diagnosing a concussion. Can you explain that a little bit then?
Well, at Michigan State, we keep it remarkably simple, that the examination process starts when the athletic trainers, Sally Nogel and Dave Yeager, reach the student athlete on the field. And it starts at that time. What is their personality like after the event? What's their level of consciousness? Do they know what the score is? Do they know what quarter it is, the play that occurred just before? So all that analysis begins immediately when they reach a student athlete that is lying on the ground or seems uncomfortable.
Okay.
After that, they typically walk the student athlete off the field and to the training table, where our lead team physician, Dr. Randolph Pearson, would begin performing a SCAT-3. The SCAT-3 was developed through international cooperation at the Zurich Conference on Mild Traumatic Brain Injury, and it is the sports concussion analysis tool.
Okay.
So the SCAT-3 looks at a variety of different neurologic fashion in an organized way so that team physicians or coaches or soccer moms or other individuals can begin the analysis of whether or not a player has suffered a mild traumatic brain injury. It's highly focused on elements of memory, cognition, mood. It has a lot to do with motor function and particularly balance. Are those things all retained? And the SCAT-3 is easy enough to look up on any website. If you would just go and look at SCAT-3, the SCAT-3 literature is there for you to look at.
Okay.
Following that, on the rare episodes where Dr. Pearson wants an opinion from neurology, they ask that a neurologist be at his side if he wishes an additional opinion regarding whether or not I think the player has also suffered a neurologic event.
Okay.
And that is the way it's been for the last 6 years.
Okay, absolutely. So what are some symptoms of someone who does have a concussion?
Surprisingly, loss of consciousness only occurs in 9% of people.
Okay.
So loss of consciousness is not a major neurologic finding in the sense that so many other concussions, 91% of concussions do not have that. But obviously if there's been loss of consciousness, that would be the preeminent signal that somebody has had a mild traumatic brain injury.
Okay.
Far more common is the presence of a headache and cognitive and memory disturbance. So if someone has had issues regarding their memory or they're having difficulty with simple questions, that could be one of the major signs of a concussion. We also notice that mood swings or change in personality are some of the subtlest findings of a mild traumatic brain injury. And that requires you to understand the players well, to realize what their background intellect is like and what their typical mood and personality are. But changes in that following a blow to the head are some of the more important findings. If memory is lost, that also is a sign of a mild traumatic brain injury.
Okay.
Headache can accompany all those features and is one of the most common complaints. The statement dizzy, I feel dizzy, is also one of the important complaints that individuals would have.
Okay.
And loss of balance is one of the features we look for carefully in our student athletes.
Okay. So you said you have to know them intellectually. So it is creating some of that close relationship with the team that does allow you to know them when they're not playing football, to know how they are a little bit.
Of course, the athletic trainers, what many people don't understand is that the athletic trainers spend anywhere between 8 and 12 hours a day with the student athletes, and they know these individuals inside and out.
Absolutely.
And so they have a very, very good understanding of personality, their cognitive background, their past medical history. Physicians like Dr. Pearson and myself will also invest time in getting to know the players through watching them at practice, interacting with them in the training room, on the sidelines, in the locker room, so that we have a sense of what they're like. And that can be very important in trying to make some decisions whether or not someone can safely return or whether or not they have to be disqualified for a game based on a concussion.
Okay, absolutely. So when someone does have a concussion, you said in the presentation that there is a 24-hour window where if they get another concussion, it would get worse per se.
So one of the pathophysiologies of concussion is changes in the way glucose is used by brain cells. With a concussion, there is an altered metabolism, particularly of glucose and several other elements. If there is an additional blow soon after the first, and it could be within an hour or 24 hours, sometimes a little bit longer than that, that can set the stage for a more difficult clinical recovery. Very, very rarely, extremely rarely, it can also lead to a thing called second impact syndrome. But I would like to highlight second impact syndrome is extremely rare. And that is a situation where there can be rapid brain swelling related to a second concussion. And in the 30 years that I've been a neurologist, I have never seen that. But the literature does show that that can occur. Far more common is where you would prolong the recovery period if somebody unfortunately plays with a concussion, then suffers an additional blow. Their clinical course could be longer than the typical recovery from concussion, which is usually fairly quick.
Okay, so talking about that recovery then, what is the process of getting a player out on the field again? There isn't a specific medication for concussion specifically, so what is that process like?
Well, that's exactly right. There is no pill you can give somebody to get rid of a concussion. If we could develop something like that, I'm sure that we would become very popular.
Absolutely.
But one of the major things is to find the sweet spot between not doing enough activity and doing too much activity. So for our student athletes, these are all elite athletic individuals, so that if you put them in a dark room and tell them to do nothing, their progress would also be slowed. And if you tell them to do too much, then the symptoms will exacerbate, the symptoms will get worse. So you have to find the sweet spot between having them do enough but not too much. Typically, the way we go after that is gradual increase of activity.
Okay.
And the mnemonic we use in thinking about that is the word brain. B for bike, R for run, A for agility, I for in red, and N for no restriction. And so in the beginning, these student athletes are seen by our athletic trainers, and they begin the biking process. Can they bike without exacerbation of their symptoms, without headaches becoming worse or their dizziness becoming worse, or issues with sleep becoming worse? If they can make it through biking exercises, they're then allowed to run. And if they can make it through the normal run paradigms, then they're allowed to participate in agility drills, no hitting, but agility drills with the rest of the student athletes. Following that, the in red means they wear a red vest, which means they shouldn't be hit, or yellow vest, which means they should not be hit. And then the N stands for no restriction. So bike, run, agility drills, in red where they're participating in drills but no contact, and then N would be no restriction.
So then they're free to play back in their normal rate.
Return to play. Now there's another thing which we should discuss, which is return to learn. One of the things that's emerged over time in the literature is realizing that if you take a student athlete and you push them back to class too quickly, where they're taking 15 credit hours or 30 classroom hours in a week's time, that may be too much when you're recovering. So we have to think through return to play, but also return to learn. In a situation where if they're having too much cognitive involvement in school, sometimes that will slow their recovery. And it's the same process. We may start them with going back to 3 credits or 3 to 6 hours a week, and then gradually increase that over time without return of symptoms. We want them to do some work scholastically, but not so much that they're not able to recover appropriately. And again, it's finding that sweet spot. And I would like to highlight that in the old literature, people never really considered return to learn issues, but it's both return to play and return to learn that are the 2 key elements.
So monitoring both, that's the way you find the sweet spot, basically. Absolutely. So then, what is something that you tell your patients then to do to recover? For example, that sweet spot, let's talk about that. Is there a common thing that is the sweet spot, or is it just individually?
It's absolutely an individual prescription. There are some individuals that will come out of their mild traumatic brain injury quickly. They'll be able to get on a bike and do 20 miles an hour for 20 minutes with no problem. There are others that when they get on a bike and they begin to bike at 10 miles an hour, that their headache will become worse. So you have to tailor the therapy in a very individual way.
Absolutely.
Now, here at this university, we're blessed with outstanding athletic training facilities, and our athletic trainers are tremendous. And these are people that are monitored carefully by our athletic trainers as we figure out what they can do and what they can't do, not only for football, but all of our collision and contact sports. And the routine is well set up. They're monitored carefully. We understand that the student athlete's health is preeminent among all decisions. And so these are very careful decisions that are made with the athletic trainer and the student athlete.
Absolutely. So lastly, let's go back to the study you've been doing with the football team. So what is that about, and what have you found so far?
One of the great things about Michigan State is that we've had wonderful access to student athletes, not only the Department of Neurology, but the Department of Kinesiology and many other academic units on campus to try to understand the process of recovery of concussion. Here, with the Department of Radiology, the Department of Family Practice, and the Department of Neurology, we've been looking at advanced MRI scans in student athletes using a thing called functional MRI. So typically, CAT scan and MRI does not show any change in individuals once they've had a mild traumatic brain injury. But we've learned that functional MRI will show differences between normal individuals and those people that have suffered a concussion.
Absolutely.
And through those studies and our university's publication in the Journal of Neurotrauma, we've been able to show some biomarkers, some radiographic biomarkers that are assisting us with diagnosis of concussion, and we think also prognosis. Further work is being done in this area. This radiologic work is through the direction of Dr. David Zhu from the Department of Radiology, and Dr. Sally Nogle, our head athletic trainer, along with Randy Pearson, have assisted with the opportunities to interact with the football team. Of course, the coaching staff and the Department of Intercollegiate Athletics has allowed us to use these advanced MRI techniques to begin to understand the disease process a little bit better.
Okay.
We're very, very grateful for those opportunities.
Absolutely. So are there any findings yet?
Yes, we've had a couple of publications, one in the Journal of Neurotrauma that lets us know above all that functional MRI is a useful clinical biomarker for concussion. And that implies, if you have a biomarker, it implies that you could tell the natural history of what will occur. And by that I mean who will have a simple concussion, recover quickly and be back on the field within a few days, and who will have a prolonged course. If we're able to continue to validate that functional MRI can assist us in that way, that would imply that the group that will do well does not need any medication to move forward. If the biomarker is successful in showing us those that will not have an easy course, that may have a post-concussion syndrome, like about 10% of people, if we can determine what that population is, as medications become available, it would allow us to provide that medication earlier on. One of the examples of all this are a variety of different neurologic diseases where MRI has helped us with early diagnosis and prognosis. We're finding that functional MRI may have that same promise in concussion, so that we'll, as the medications become available, we'll be able to prevent post-concussion syndrome in an easier fashion. And this was pretty exciting in terms of presenting this information at the American Academy of Neurology, along with the Big Ten Ivy League Concussion Consortium. We were encouraged to move forward and publish these data, and that's been a very gratifying thing.
Absolutely. And so you'll continue with the study and further as we go?
Yes, of course.
Absolutely. Well, I look forward to hearing more about it and learning more about concussions once those numbers are in and once that research is done. Thank you so much for being here, Dr. Kaufman.
Thanks.
Thank you so much.